orthobiologics can serve as a first-line treatment when you have appropriate patient selection. It all comes down to patient selection. So we don't propose to cure everything. However, our thinking has evolved. You could be the best surgeon on the planet with the best surgical procedure, but if your patient doesn't trust you, they're not going to be compliant.
I think my opinion is orthobiologic treatments will be first line treatment for musculoskeletal care in the next 5 years. This is history in the making and very, very exciting. Welcome, everybody, to Conversations in Regenerative Medicine, where we're going to be exploring the frontiers of platelet-rich plasma, bone marrow concentrate, and adipose-derived microfat, and the other more controversial, cutting-edge topics where I and my guests are able to delve into a little bit of the behind the scenes, if you will. So as we get started, I'll let everybody start to filter in. For those of you who don't know me, I'm Dr. Ariana Demers. I'm a board certified fellowship trained orthopedic sports medicine surgeon and obsessed with regenerative medicine. I also train and educate in orthobiologics and ultrasound, and I have successfully moved my rural orthopedic practice away from insurance, and I focus on cash-based orthobiologic procedures and wellness. And the thing I'm most passionate about is helping other doctors incorporate orthobiologics seamlessly in their practices. I'm so excited to introduce to you my next guest, Dr. Chris Rogers. He is a powerhouse in the field. He is board certified physical medicine and rehabilitation expert with 25 years of experience in the non-surgical orthopedic care. He's a global leader in regenerative medicine. If you've never heard him talk, you're missing out. If he is on the docket, you need to buckle up and hold on to your hats because his talks are awesome. If you get the opportunity to get the talks from either the Biologics Association, which we just hosted, or from the most recent Interventional Orthobiologics Foundation meetings, please look him up. He is not only humble, but man, I love his talks. They're so entertaining and so inspiring. He's also a pioneer in orthobiologic therapies. I'm going to let him tell you a little bit more about that pioneering spirit. And then additionally, he has some innovations that I'm also going to have him talk about from the Data Biologics registry, as well as some FDA approved stem cell trials. So without further ado, I am going to just welcome everybody to this exciting fireside chat, where we get to hear from internationally renowned experts in regenerative medicine, explore more controversial topics in orthobiologics and regenerative medicine, and then gain actionable insights into how exactly you can implement these in your practice and get your burning questions answered in real time, which is amazing. So thank you so much. And I'm going to make one bold statement, and then I would love to hear from you. I think my opinion is orthobiologic treatments will be first line treatment for musculoskeletal care in the next 5 years. This will be standard of care, and we will be able to serve our patients better because of it. So Chris, welcome. Thank you so much for taking your time. I would love for you to share a little bit more about you and kind of all of the amazing things you've done in the field thus far, and then maybe share a couple of your pet projects that you really are excited about.
Well, thank you very much, Ariana, for inviting me today to talk with you. I always love talking with you. I had the pleasure of just talking with you a few weeks ago in our nation's capital, Washington, D.C., where you and I both presented some information to our colleagues. First of all, I share your enthusiasm for this field. I'm also obsessed about orthobiologics and regenerative medicine. I mean, it's really what we got into medicine for in the first place, was actually help people to heal. For so long, my background, you asked about my background. I'm a physiatrist, physical medicine rehabilitation board certified. And then I did a fellowship in interventional spine care. So I was basically injecting cortisone in people's nerves and joints and discs and things that we would probably laugh now that that we did that, but that in many places that still is a standard of care. But I agree with your statement here.
Don't miss out. Please subscribe to our newsletter now to stay ahead of the world of orthobiologics. You can find the link below. Additionally, if you're ready to start this journey with me in my Orthobiologics Masterclass, come join us.
Orthobiologics, based on the outcomes that we are seeing with our patients, based on the now robust scientific literature, registry data, all pointing in the same direction, showing that orthobiologics can serve as a first-line treatment when you have appropriate patient selection, right? It all comes down to patient selection. So we don't propose to cure everything. However, our thinking has evolved. So I first got excited about regenerative medicine. It's been, God, 17 years. I can't believe it. So here I am slogging along, doing, non-surgical sports medicine, treating arthritis, treating tendon injuries, treating herniated discs, things like this, with cortisone and physical therapy, and when appropriate, referring to surgeons so they can do their work. And that still has its place, right? We're not eliminating those tools that are shown to be helpful in our toolbox. But a friend of mine who was a world-renowned golf instructor, who actually co-founder of something called Titleist Performance Institute, knew about PRP. I didn't know about it. He knew about it because athletes were getting treated in Europe at the time. He ended up tearing a tendon in his elbow, asked me to do PRP. I said, what the heck is PRP? I don't know. So I did a little research. There was that one published paper, Alan Mishra from Stanford, thankfully had published a paper on PRP for lateral epicondylitis. So I had been doing ultrasound guided injections since 2002. So I could see the tendon tear. I found a centrifuge somewhere. I made PRP. I had no idea what I was doing. Injected way too much volume into that poor little tendon. It was painful.
Oh, yeah. Back in the day, remember we used to torture everybody?
I tortured the poor guy. It was crummy PRP. It was bloody PRP. But I, would have him come to the office every 2 weeks, and I saw that tendon tear get smaller and smaller and smaller and smaller on the ultrasound. My God, my mind was like blown. I could see the neovascularization, all the Doppler signal on ultrasound, all this stuff. So that was my first foray into regenerative medicine. And at that point, I decided I got to learn everything there is to know about PRP. So like you, went to the conferences, read the books, read the papers, went to friends' clinics, and learned as much as we possibly could. And it just gets more and more exciting as we go on for the next decade and a half.
Right, absolutely. So, will you share with our colleagues here on the call a little bit about two things and that really kind of you have been an innovator for? Number one is the Data Biologics data collection system and registry. And then the star of the show, a little bit later, we'll be talking about what else you're working on currently.
Yeah, so when I first started doing PRP treatments for patients, there wasn't a whole lot of publications. And so we were using it as the last resort, which is wrong. I can just flat out tell you right now, it's wrong. We didn't know, right? So we felt bad charging patients for something that we didn't know whether or not it worked at the time, so 16 years ago or so. And I think the first 20 or so patients I just treated for free because I was learning along with them. But it was very clear whenever I went to a conference or talked to colleagues, it was clear that we need more data, more data, more data. And I realized that for every published paper that had, maybe 20 patients in the study, there were probably 200 patients that were being treated by pioneers in the field, and all that data was being lost. So I was at a conference with Jerry Malenga, our dear friend, and Jay Bowen, and we had been collecting data on Excel spreadsheets for a long time, just handing out surveys to patients. And we said, everybody's walking around with one of these things in their pockets. Maybe we can figure out how to collect data in a way that's easy. So we went with what we call the SUP principle. It had to be simple to use, user-friendly and practical. We wanted practical data. And so we started Data Biologics, which is a company and a product. And our dear friends in the field, this is still a family of regenerative medicine doctors. So we're still the minority, right? This is not standard of care yet. So everybody's our friend. And 50 of our fellow colleagues agreed that this was important. And thanks to them, they adopted the software. And it's just grown and grown and grown. I think we're over 30,000 patients in the registry now. I think we have over 300 doctors using the platform. And we're getting really cool data insights. You've presented some of your outcomes at conferences. Other physicians have done the same. And it's just allowing us to get real data in real time. And a lot of physicians, I know you're doing this, are entering your cellular data on your PRP. So we can just sort of tease out where we can get another 5% in the response rate, another 10% in the response rate. PRP works pretty well out of the gate. I tracked my first 200 patients after 2 years, and about 75% of them were getting better, even though I had no idea what I was doing, 16 years ago.
Mm-hmm.
So now we're getting more, low 90s, mid 90% response rate. And there's lots of different ways you can define response. My definition is the patient happy with the result a year later after treatment. There's a lot of other outcome data we can look at, but practically speaking, I think that's probably the most important. So Data Biologics covers probably 50 or 60 different types of treatments now. A lot of companies are using the platform to do pilot studies to learn where their products may work best or not as well. So it's really grown beyond what my initial thought was for the platform.
That's so awesome. Yeah, it's been really instrumental for me being able to follow my patients and know what my outcomes look like and know with really pretty significant confidence what I can expect, what in my hands, what my patients can expect, and where do I need to get better, where do I need to critically look at this. So it's been awesome. So thank you so much for sticking to it. And the road of entrepreneurship is not always easy and not always straightforward, but I think you've made such a contribution to the field, and I think it's so needed to be able to capture that data in the private practice and cash pay realm, where, the majority of registries are university-based, and we don't want to miss this huge amount of data that is just poof, gone out into the atmosphere. And, there's doctors that are doing a great job. So thank you so much for creating something that is easy to use and doctor facing and created for doctors. So that's been awesome. So here's what I know is successful integration of orthobiologics in your existing practice is hard. And I know there's so many of us that want a successful orthobiologics practice. We know that orthobiologics is the best treatment for our patients, but how do you actually become successful at this? And maybe some of our, attendees have tried some things, and you say, well, I don't know the science, I don't know the technique, maybe I don't know about talking about cash, or marketing or sales. Like, how do we do this? And it's not your fault. We didn't learn this in school. And I'm sure people have said, well, maybe I'm just not good at business. And maybe some of us are struggling with how to be successful and capitalize on this $4 billion orthobiologic market out there. So I definitely think we deserve more. And I'm sure all of us have thought, why is this so darn hard sometimes? But what I ask people to do is just put in the chat what you're struggling with in the chat so that I can kind of make sure that we hit all the high points with this. So the question that we're asking is, how do we win at this? Well, we are talking about the science today, and I'm going to ask Chris some really very fun questions as we dive in. But we also need to consider how we talk about this with our patients. And so, Chris, when we talk about all of these high-level scientific doctor type questions, I would love for you to and we'll talk about how do we translate this for our patients as well, so we all win. So obviously we need a system, right? And we're not going to go over all this today, but if we are going to get a little further down this journey to be wildly successful in your orthobiologics practice. So we're going to start with that orthobiologics knowledge today. So Chris, why don't we just get down to business? And yes, we have questions. And our first question that I have, and maybe share a little bit about your expertise in this field, is what you guys maybe don't know is you are looking at Dr. Chris Rogers, who is the preeminent expert in adipose-derived stem cells. And more importantly, adipose-derived stem cells that are culture expanded. And so, Chris, can you give a thumbnail version of what you're doing with these stem cells? Because, last time I checked, culture expanded stem cells weren't allowed in the United States.
Yeah, and that's still true today. So they're allowed, but only under certain circumstances, right? So first of all, what is an adipose-derived stem cell? So the MSC that Arnold Kaplan described and published on in the 80s and 90s, and by the way, it was a dinner with him over a decade ago that got me into learning more about adipose. I give him a lot of credit for my career path change. But understanding that, that the cells within the adipose tissue are very robust for managing inflammation and for stimulating tissue regeneration. So that's why we want to use these cells. Prior to that, we were deriving them from bone marrow aspirate, which is great if your patient's younger, not so great if the patient is older. But currently, we are only allowed to use minimally manipulated tissues. So this is sort of my soapbox lecture. I'll try not to lecture too much, but I do not call BMAC, bone marrow aspirate concentrate, or MFAT, microfragmented adipose tissue, stem cell therapy. Don't call that stem cell therapy because when I think of stem cell therapy, I'm thinking about high dose cell therapy. So more than 10 million cells. And if we're gonna promise patient outcomes, then we have to base it off, the literature that we're quoting from. So anyway, so microfragmented adipose tissue obtained through simple lipoaspiration will get us on average about 500,000 to 1 million MSCs per treatment. So if you're injecting 10 cc's of microfragmented adipose tissue, based on the cell counts that we've done with the lab that I work with, you get about 500,000 to 1 million of these MSCs. And it varies widely. Strangely, it doesn't seem to correlate very much with age, like where with the bone marrow MSCs. I think one of the highest cell counts I ever measured was in an 82-year-old woman. So it really is patient variance that is the greatest cause of this variance. It's not the technique, it's not the device you're using to make the MFAT. The challenge though, so I adopted MFAT about, like I say, over a decade ago, was blown away by how well it worked for larger tendon injuries or for more severe osteoarthritis. I was tracking data in my patients and I was getting better outcomes than I was with PRP. So I continued with MFAT. But then I realized if we're going to move the science forward, we need to standardize, you hear this a lot. We need to standardize the product. We need to standardize the procedure. And to standardize it, that means you're actually counting the cells. You're doing flow cytometry. You're characterizing the cells. If you're doing culture expansion in a GMP facility, you are testing for sterility. These are things that are highly desirable in a product. And I dream of the day that we have an FDA-approved MSC product in a bottle where you know exactly what you're getting every time, and you can use it with comfort in knowing that it's safe and effective. When you manipulate that adipose tissue beyond the simple rinse, wash, resize, centrifugation type process, the FDA puts you in a new category, 351 product, which requires going through the BLA phase 1, phase 2, phase 3 process. So I'm involved with a company called Personalized Stem Cells, and I was able to conduct a clinical trial where we made stromal vascular fraction, which is a little bit more MSCs than we would get from MFAT, but not as high as you would get with culture expanded MSCs. But we showed really good results. And I haven't published my 3-year data, but my 3-year data is as good as my 1-year data, where 88% of the patients who were told they needed knee joint replacement are still doing well without surgery. So, if we can cut the number of joint replacements in half, that's going to be huge cost saving to Medicare and other insurance programs. So, but that aside, it's a simple procedure. If you can have a small surgery instead of a big surgery, this is what arthroscopy was able to do. you would choose that. If you can have a shot as opposed to a surgery, you would choose that as long as the outcomes are good, right? So still a lot of work to be done, but go ahead and do yourself a favor. Do a lit review on PubMed. Look at some of the meta-analyses on culture expanded MSCs, and you will be shocked at how good the outcomes are, regardless of the method used to culture expand the cells. There is a little bit of, the soup is made differently in different labs around the world, but generally speaking, we're talking 85 to 90% of patients getting significantly exceeding MCID, specifically for knee osteoarthritis. There are limited number of studies in other areas of orthopedics, but knee OA is where we see the biggest benefit. Two big myths that the literature dispels. Myth number one, using allogeneic cells from perinatal tissue, a baby MSC, if you will, is superior to an 80-year-old woman's adipose MSC. Not true. The data does not support that. Do not let your patients tell you that I'm going to go to some country and get some baby cells because they're better than my cells. Not true. Second myth, MSCs can't grow cartilage. Not true. We have robust published data now out to 5 years showing that there's improvement in cartilage thickness and cartilage density in published clinical trials in the knee. So most meta-analyses that I've reviewed support that. So those are two common myths I hear.
So, holy cow, stop the presses. So you're telling me that culture expanded cells,
Yeah.
treatment with culture expanded cells
Yeah.
can improve your cartilage.
Oh, for sure. Yeah.
How much, what are we talking? Is this 10%? Is this 50% of the
So
people?
the natural progression of osteoarthritis is you lose about 1 to 2% of cartilage in your knee, let's just say, on the tibia, on the femoral condyle per year. So there's a slow degradation. Most published that, so we're talking prospective randomized clinical trials. One group gets placebo, one group gets culture expanded cells. And I'm just talking broadly. Adipose primarily outperforms bone marrow cultured MSCs and outperforms umbilical cord MSCs, but they all do well. And what you show is in most published studies, you will see an improvement in the thickness, depending on how they measure, right? So in some cases, MRI, it's very difficult. The resolution of MRI is not great. So there are software programs where you can measure the cartilage volume. You can measure the size of the defect. You can go in there with second look arthroscopy and poke at it, do your ICRS grading, or you can take a biopsy and say, holy crud, we've got articular cartilage here that's well integrated into the margins. So it's extremely exciting. If I were an orthopedic surgeon, I would definitely look forward to the day when I can add this to my, my cartilage repair surgeries.
Yeah, holy cow. That is, I knew the SVF literature did support cartilage improvement, but I didn't realize that it was so robust in the culture expanded experience.
It is. And then in the chondral defect literature, you're familiar with Dan Sarris's lab at Mayo Clinic, where he is using autologous chondrons. So he'll take a little chunk of your cartilage from a non-articular surface and combine it with allogeneic, so donor adipose MSC, and showing really robust cartilage healing for large osteochondral defects. So the devil's going to be in the details: how many cells, what kind of cell, what treatment, what's the right patient. But again, just like with PRP 16 years ago, we're seeing great results with a very limited understanding of this technology.
Don't miss out. Please subscribe to our newsletter now to stay ahead of the world of orthobiologics. You can find the link below. Additionally, if you're ready to start this journey with me in my Orthobiologics Masterclass, come join us. Yeah, that's amazing. So just to be clear, there are no products in the US that are approved by FDA for culture expanded at this point, correct?
Correct. In orthopedics, we have one approval for graft versus host disease. That was big news last December when Mesoblast, which bought Osiris, which was Dr. Arnie Kaplan's company that he started back in the 90s, They got through the gauntlet and they got FDA approval for their culture expanded bone marrow MSC product for graft versus host, pediatric graft versus host. But for orthopedics, we do not have an FDA approved, and it's going to be a while before we have an FDA approved culture expanded product. So the only way patients can get them in the States are if they're in a clinical study. We plan to run a phase 2 study this year for knee osteoarthritis, single unilateral moderate knee osteoarthritis, basically Kellgren 3s. And then that will be with culture expanded MSCs, adipose, autologous. And then if you don't qualify for a clinical trial, if you're a patient, you might be able to get in under expanded access if your physician applies to FDA and gets approval to do, special case, but that's not broadly available.
So that's awesome. So tell me this, because I know this is going to happen to doctors. Oh, well, we have this product, Mesoblast. It's approved by the FDA. You can just use it off label and inject it into your patient's knee.
Yes, you can, but guess how much it costs?
How much does it cost?
$1.5 million.
Fair enough. Well, I feel like maybe for $1.5 million, our patients could probably do something different besides Mesoblast.
Yeah, I think so. I think they have better options, more cost-effective options.
Fair enough. Well, we have more questions. So, does the therapeutic gain of culture expanding adipose-derived stem cell outweigh the ethical concerns for noncompliance and patient safety? I think there's been some patient safety concerns. Can you go into the patient safety concerns a little bit?
So you're saying the safety concerns with culture expanded cells
Yeah.
and not ethical, but you mean safety concerns?
Yeah.
Oh, we have robust literature now showing extremely good safety. What do we track? So in our study, with our SVF study, we track per any FDA approved study, you're tracking adverse events. So if I inject your knee and then you feel so good that you are now riding your bicycle every day and you crash into a fence like one of my patients did and break your arm, that's an adverse event, but it's not a treatment related adverse event. But if you look at the literature, you will find that we really do not see serious adverse treatment-related events with culture expanded MSCs, which is funny because that's in contrast to what you hear in the media, right? You hear it's going to cause a tumor. It's going to blind you. Yeah, there were 3 cases where nurses injected SVF into patients' eyes and they were blinded, but that was just bad judgment. That was bad healthcare. That was not bad product. And so,
Gotcha.
yeah, so,
Okay. So, I mean, gosh, this sounds like it's too good to be true, but maybe it's just the new reality. So, we have obviously more questions. And so, the question I have is, are we overpromising what culture expanded can deliver due to these inconsistencies? And the biggest inconsistency is the patient. So how do we pick those right patients for culture expanded options or even a consideration? Where would you use regular PRP versus MFAT versus FVF versus culture expanded? Who would be that perfect patient for each of those identifications?
yeah, the perfect patient for culture expanded adipose MSCs appears to be that patient with more advanced joint disease, but not so advanced that they have a biomechanical problem. So a patient with a root tear of their meniscus that's unstable with extrusion of the meniscus, a patient who has a grossly unstable joint due to ligamentous injury, a patient with high degree of valgus or varus deformity. That's a mechanical problem that requires an orthopedic surgeon, in my opinion. It doesn't mean you don't go back and augment the biology later with cell therapy, but you gotta fix both problems, the anatomical problem and the biologic problem, right?
Okay.
And so
So barring those issues, you would say injection-based therapies is a consideration when we get this culture expanded approved, but and SVF is coming shortly. What do you think the difference between SVF and culture expanded? Is there going to be a time frame where SVF is allowed and culture expanded is not?
yeah, GID, you're familiar with GID. They're in phase 3 with their device. This is a device you will use on site in the practice to manufacture SVF. So we should be getting that reasonably soon. That they should be able to get approval I don't know what soon means, a year, 2 years. We're in weird times. We have a new, half the FDA just got fired. So
Right.
I don't know what to tell you what the future looks like.
Yeah. Maybe faster, maybe slower.
Correct. Yeah. So your guess is as good as mine. But if we're, based on what the messaging has been from the FDA for the last 20 years, these companies, including the company I work for, has to get, phase 1, phase 2, phase 3 approval, BLA approval by the FDA before these products are available to us. For
Okay.
GI, that's a device approval. So that's different than a drug. And then you ask, how does one compare to the other? How does SVF, which is a lower MSC count, but has other cells in the mix, right? You got
Yeah.
endothelial progenitor cells work very nicely with the MSC for certain kinds of indications, like patients who have wound healing issues. To me, that's a match made in heaven. People with vascular issues, SVF is remarkable. So, but for culture expanded cells, strictly MSCs, that's going to require an approval. But we have approvals in 10 countries around the world. You go to South Korea, it's already approved for NEOA.
Okay. All right. Well, that's really exciting. And I really have I'm like, when can we start, right? So I have more questions, obviously. So this is the last one that I think it really requires us to think a little bit about. But, should there be a global consensus or registry for clinics using these culture expanded autologous stem cells? Or are we still in the Wild Wild West scenario? I know offshore culture expanded cells, you just said in 10 countries it's approved, right? And so there are clinics around the world that are doing these procedures. And the question is, how is it up to the clinic to police themselves? Is it up, how should we proceed? Or what would be best practices to be able to proceed?
Well, best practices, I think, at this point would be if each clinic globally who is doing this kind of work, because it is still investigational, should make their clinical outcomes transparent, available. You don't get this. If you go to Mexico, Central America, you go to Bahamas, you go to Cayman, to give Chris Centeno some props here, Regenex is very transparent with their outcomes. So they do culture expanded MSCs, bone marrow down in Cayman, and they publish their results. I think every clinic should do that. I think they should maintain a registry and they should share those outcomes. They may do that on a one-on-one basis with a potential customer, but they should publish their outcomes so that
Yeah.
we can all be aware of what's best practice.
Well, maybe we can get a list together of all our friends doing these and say, hey, well, let's get a special journal article together and say, this is what you can expect from our worldwide experience with Culture Expanded. Because it's a small cohort right now, and you are, leading the way along with others who are doing this. And, so I think if we can be collaborative, that would be best practices. And instead of being proprietary about that, not to give away all of your, hard-earned stripes, but at the same time, publishing those results, I think, is really important. And say, hey, listen, we're getting great results. Please, everybody else, try to replicate this and prove that this is a real thing.
Yeah, that's again getting back to Data Biologics. That's why we created that registry. So I wanted to know who was, getting the best outcomes. And it's not like there's best doctor. I know your outcomes, Dr. Demers. I'll just give you a little shout out. I know your outcomes are extremely good. I know you're in the top 8 physicians in the United States in terms of your long-term patient outcomes. So congratulations for collecting the data and congratulations for providing great care. I think your secret sauce is probably your orthopedic surgery training was very good. And so good patient selection, you know how to do an accurate, complete diagnosis, and then you have excellent skills. I think that's all necessary. So anybody on the call who's saying, how do I get into regenerative medicine? We didn't learn this in med school. We didn't learn this in residency. So you got to go to conferences. You got to read as much as you can. You got to get your skill set up, whether it's surgical skills or injection skills or ultrasound guided injection skills. That's all important. I think with the patients, I think informed consent is mandatory. And informed consent means you give the patient an honest expectation of what their outcome may be and what their options are. And when you don't know, you just say, I don't know. And that will boost your satisfaction, because if your patient's expectations are appropriate, then they will be more satisfied because they're on the same page as you are in their understanding of what to expect.
Yeah.
Yeah.
Awesome. Awesome. Well, you bring this up, so this was perfect. So what is the next step, right? And so you need our practice launch system, right? You want to be effective at this. And I appreciate you sharing your knowledge and your expertise. I mean, you're a giant in the field, and I feel so fortunate to have you as my friend and my colleague. It's been amazing. And we could talk all night about very nerdy things and just continue. It's awesome. But part of this is, how do you find the right patients? The ones who are right for regenerative medicine, who are the ones who need your help, right? And so we talked a little bit about, how do you attract the right patients who are good candidates for this? And then, it goes into, how do we create a nice cash-based business? How do you convert with good results? And how do you put it all together for success, not only for the patient, but for yourself as well? So I have a really fun little Regen patient magnet method. It's a little webinar that I'm hosting this coming in a couple of weeks. And so if you're interested, please scan the QR code, come register, and share this with your friends. It's going to be figuring out how we choose those right patients and how we attract them to our clinic, how we get them to understand what we do and how we can help them. So if that's something of interest or need to you, please register. If you want the fast track, I'm very excited to tell you we have a Business of Orthobiologics live at Toby in August in Las Vegas. You cannot afford to miss this event, because this helps you seamlessly integrate PRP and orthobiologics into your workflow. You get a step-by-step roadmap on how to attract patients, the right pricing, and then proven strategies to run a profitable and successful cash-based orthobiologics practice. So please, please, please come. It's going to be so much fun. The price for a full day of the roadmap, patient-centered branding, pricing models, and insight from successful physicians just like Dr. Chris Rogers will be there. And then that is the price for the VIP lunch. If you want to hang out with me, that would be awesome. So this is the QR code. Again, Chris, thank you so much. I appreciate you and your time. And then I did want to open this up to any questions. So if you have questions, please pop them in the chat and we'll get that. Any questions for Dr. Chris Rogers, either raise your hand or pop it in the chat and we can unmute everybody.
There's a question that's relevant that someone posted is, how do we convert patients?
Yeah.
And the old adage that patients don't care how much you know until they know how much you care is absolutely true. We work in the trust business. You could be the best surgeon on the planet with the best surgical procedure, but if your patient doesn't trust you, they're not going to be compliant. And what you're looking for is compliance, and you need to convey to them the confidence that you have that your plan is going to work for them. And that means you've taken the time to listen to their history. You've taken the time to do a quality physical exam. You know how to read imaging. You know how to explain that imaging to the patient and give them some sense of what they're dealing with, so that you're not just coming out of left field with some idea that they don't even know what you're talking about. The second is, again, this is self-serving, but Data Biologics has helped me quite a bit in converting patients. I have a physical therapist who I've known for a long time, and she trusts me, and she had a TFCC tear, and she asked me, will PRP work? She treats all my patients that I've treated with PRP, and so she knows what we do. And I said, well, gosh, I don't know if I've even treated a TFCC tear with PRP. And I pulled up the Data Biologics registry, and lo and behold, over the last 5 or 6 years, I've treated 10 of them. I don't know how I didn't remember, but there they were. And I had their 12-month follow-up data, and it was thankfully, very good. So I said, well, apparently we get good outcomes with the with PRP here.
Yeah. I also use my Data Biologics registry data because honestly, that has really helped drive what they can expect in my hands, what I can deliver to them. And so that has helped as well. And if you don't have those outcomes, you can use the literature and say, listen, what we know from the science that we have to date, this is the expectations that we can do when we use these techniques. And that's not wrong. I think that's helpful in the conversion process to equip your patients with as much information about what they can expect and what they can expect to avoid if they choose this treatment. Meaning, how long is it going to last? Can they avoid knee replacement altogether? And the exciting thing about what you're telling me about culture expanded is, man, this horizon is bright. I am very, very excited to be a part of this. And for everybody on the call, this is history in the making and very, very exciting. So, Chris, anything else that you are wanting people to understand about what we've talked about today? Or any last parting shots, if you will?
I will add that, again, self-serving.
Yes.
Company that I work for, even though we do not yet have FDA approval for culture expanded cells, any patient, any person can bank their stem cells now. You can. My wife and I both, Dr. Ambach, who you know and love, did lipoaspiration on us. Our MSCs have been culture expanded. I now have 20 bottles, each bottle containing at least 15 million culture expanded MSCs, all manufactured in GMP facility. I can't get them yet. I can't use them yet unless I'm in a clinical trial perhaps, or have an expanded access use. However, I'm getting older and those cells are not. They're sitting there in suspended animation, frozen, and that is perfectly legal. That lipoaspiration is a medical procedure, perfectly legal. To culture expand, the GMP lab has all the appropriate state and federal tissue license, banking license. So it's just a matter of time before we get the approval to use them as a treatment. So
Well, awesome. Yeah. So what we'll do is when we send out this replay, we'll send out the information about this ability to bank. If you're collecting adipose or MFAT or any of that, your patients can actually bank their cells. So that's really exciting and good job. Kudos to you.
yeah, any patient that I do MFAT for, I'm always telling them, let me take just a little bit extra and let's save it for the future. Or if you do a knee scope, say you do any surgical procedure, you can take a little surgical fat. That can also be turned into culture expanded cells.
That's
So
amazing.
that's available now. There's a couple of companies around the country that do that, but they're not on the path to get FDA approval, and you can't get your cells back if it's not FDA approved.
Gotcha. So Personalized Stem Cell is the company you are a part of, and we will send that out and make people aware that this is available. So thanks so much for sharing your time. Everybody who's been on the call, any parting questions? Otherwise, I appreciate your time, and come join us either on our 1-hour webinar on the Regen magnet method, or if you want the fast track, come to Bob Live at Toby, which is in August in Vegas. So hope to see you there. And thank you so much. Thank you all.
Thank you very much. We'll see you in Las Vegas.
Yes, absolutely.